Hi, I'm Dr. Lucy Cunnama, and I'm a health economist working in the Health Economics Unit and Division at the School of Public Health and Family Medicine at the University of Cape Town. My primary work focuses on economic evaluation, and I work in the disease areas of tuberculosis, HIV, child and maternal health. Today we are going to talk a little bit more about costing in this part 1 of a series. So in this lecture we're going to cover some of the basics. We're going to cover what costs are, look at financial and economic costs, talk a little bit about opportunity cost, total costs, the different approaches and methods one can use, and different perspectives one can take. So the first question is, what are costs? Economists define costs as the value of the resources used to produce something. Therefore, costing entails identifying, then measuring and valuing resources. And this relates to prices and quantities, or P's and Q's. So quantities can be something like how long it takes to do a piece of work, or it could be a quantity of consumables used. And these are collected through different methods. The prices are then collected and allocated to these quantities. And if the prices for the exact item cannot be sourced, then we can use a shadow price, which is an estimate to reflect the value of these resources when we use an average of multiple estimates of local market price. We must also ensure that all prices are adjusted to the same year, and this is usually the final study year. When we talk about financial costs, these represent the actual monetary expenditure on goods and services that are purchased. So, for example, we might be looking at medication for a particular set of patients. This is in contrast to economic costs, which reflect the full value of all resources utilized in producing a good or service. So, for example, the value of all resources used in providing chronic hypertensive medication, that's high blood pressure. And the resources can be time of the doctor, time of the nurse. If we have a volunteer pharmacist in place, that would be the time and cost of the pharmacist's time, the medication dispensed, the use of a donated blood pressure cuff, building space used, etc. So economic costs include all the resources, whether they are paid for or not. So if somebody volunteers their time or a good is donated, then we include this. And the idea here being, if we were to try and replicate this service or intervention in a different facility, we would need to know all of the different cost components so that we could replicate it, even if those were volunteered, time was volunteered or goods were donated. And opportunity cost is an important concept within health economics in general. And an opportunity cost refers to the value or benefits that you could have had if you'd made a different choice. So what you would have done if you hadn't made the choice that you did. So if I offered you a new house, or I offered to pay for all of your university fees, what would you choose? If you choose the payment of your fees, then the opportunity cost would be the house. And if you choose the house, the opportunity cost would be your university fees. As scarce resources must be allocated between different competing alternatives, if 5 million rands is spent on the prevention of mother-to-child transmission of HIV or PMTCT, then the cost is 5 million rands, but also the other health programs that might have been sacrificed in putting this in place. So if we were going to have additional ART coverage instead, then this is the benefit that we miss out on. In terms of total costs, one way to calculate total costs is to add both fixed and variable costs. So total cost being the entire cost of producing the service. If we think about fixed costs, these are the costs of renting a clinic building, which we can see would not vary regardless of whether 3,000 or 30,000 women attend, for instance, maternal services. Whereas variable costs, such as medication costs, do vary with scale. So if we have 30,000 women accessing maternal services, the cost for that medication will be higher than if we only have 3,000. The other way of calculating total costs is to add capital and recurrent costs. We can calculate the capital cost, and this is something that lasts for more than 1 year, such as a building which might last for, say, 30 years. Or it may be professional training, the effects of which might last for 2 years. A recurrent cost is the value of resources or inputs with useful lives of less than 1 year. And recurrent costs include items like salaries, transport, operations or overheads, and maintenance, supplies, pharmaceutical products, and vaccines. And these recurrent items can be purchased irregularly. So, for instance, in a clinic, we may only purchase consumables every 3 months, and we can calculate what this would be over the full year. In terms of the different approaches you can take, if we had an ideal world, guideline costing or normative costing would be equivalent and would amount to the same thing as real-world costing. However, in most cases, it's likely that there will be deviations in the real-world costing. And this is often due to practical changes to the guidelines. So if patients live further away, perhaps they will only collect their medication monthly rather than weekly. A full costing involves calculating the costs of producing a good or service, using, for instance, a bottom-up approach, which is an ingredients-based approach, where all the resources involved in the production are evaluated appropriately and then included in the cost. So, for instance, here we would include the hospital space, the staff time, the medication dispensed, diagnostic tests used, and the consumables. For instance, if we were looking at the cost of a stroke patient. Whereas with an incremental costing, we're only calculating the change in the usual costs of production, and these are associated with the provision or service of a service or upgrading an existing program. So, for instance, if we put in place consultative palliative care services for stroke patients, where the costs of being an inpatient are not collected, but the additional palliative doctor and nurse's time and additional pain medication are costed, this could be an instance of incremental costing. We can also perform a bottom-up costing or micro-costing, and this is a detailed approach which uses an ingredients-based approach to measure all the resources used in the provision of a specific health service or intervention. So if we are looking at how much a TB microscopy test takes to perform using a bottom-up approach, we would identify all the resources used, and these could be quantifying the technologist's time, measuring the building space, measuring the time that a biosafety cabinet is used, counting how many chairs and tables and microscopes are used, and looking at consumables such as glass slides. And then through interviews and observations, we would gather all this data, and then we would assign the appropriate prices or costs to these items. In contrast, a top-down costing or gross costing or step-down approach is a more aggregate method, and it is often used in high-income settings where there's routinely available data. So, for instance, if we want to know the cost of a patient receiving oral contraceptives, the overall expenditure of running the family planning clinic within a large hospital would be collected and then allocated. And then using the number of patients seen in this clinic, we would use this utilization data to divide it further into a cost per patient receiving oral contraceptives. It's important to understand how we think about costs, so the perspective that we take. The perspective that is most commonly used is a healthcare provider perspective. And this would be, for instance, if we wanted to look at the cost of treating a patient who suffers a heart attack within a hospital. And this is a cost of providing a specific service from the perspective of the facility. In contrast, a patient perspective would assess the cost from the point of view of the patients themselves or their households. And this would include the cost of accessing and seeking healthcare, as well as consuming healthcare. The so-called gold standard perspective is that of a societal perspective, and that is because this is the broadest perspective. So it involves both the provider and the patient costs. It can also include the costs to other sectors. And this is the perspective that can be used if one has the skills and the resources to incorporate this work. Thank you so much, and I look forward to chatting with you more, and I hope that you enjoyed this lecture.